matter of interest, this is that I'm not a surgeon, and I'm very critical with regard to sentinel node biopsy. You know, when a surgeon talks about sentinel node biopsy, it's always beneficial. When a non-surgeon like me is talking about sentinel node biopsy, it's always critical. But I will try to be fair and will pronounce, or will spend most of the time on data, on objective data. What are the rationales for performing a sentinel node biopsy in melanoma patients? Well, there are three potential rationales: therapeutic, prognostic, or diagnostic. And we will explore all of them. Now, I will start with the history of sentinel node biopsy because I think then you better understand why we are doing this. Then concept and evidence, I will present you some data, and then question and answers, and hopefully a fruitful discussion afterwards. Let's start with the history. Now, you've seen this picture before. This is, of course, an obvious melanoma, and you can see the lymph node in the groin, obviously enlarged. And you know, this is a photo from the 1940s in the United States. And what did they do then, 60 years ago? They removed the primary with some safety margin and also, of course, the lymph node. This is what we call therapeutic lymph node dissection. Therapeutic, why? Because there is already metastasis. And now, which safety margin did they use then? This was the safety margin that they used then. Now, the question is, did this safety margin save the patient? No. Did the node dissection save the patient? No. In this case, not. This is what we call therapeutic lymph node dissection. When there is obvious metastasis, we remove the lymph nodes, and that's the point. Now, what about elective lymph node dissection? What is elective lymph node dissection? Well, that's easy. Elective lymph node dissection is you have a primary tumor, a melanoma, and you remove the lymph nodes, although there are no metastases clinically. Why you want to do that? Because you think that there is an increased risk to have metastases that are subclinical, micrometastases. So if you remove them, that's the dream, then you will prevent further metastasis. So this was also done for quite some years, until there was a study by a very famous Italian, I think you all know this study, done by Veronesi in the 1970s already by the WHO melanoma group, and he proved in a randomized controls study that elective lymph node dissection is not beneficial to melanoma patients. And they included a lot of patients, and 250 in each arm, one who received elective lymph node dissections for lymph melanoma, arms or legs, and one who received only excision of the primary tumor and observation. And there was no benefit for elective lymph node dissection. You know that? Elective lymph node dissection in malignant melanoma of the limbs does not improve the prognosis and is not recommended when patients can be followed at intervals of 3 months. New England Journal of Medicine, 1977. Yeah? But this did not stop elective lymph node dissection. Surgeons continued to do that, and maybe until 1996, another important study, BULGE, efficacy of elective regional lymph node dissection for thick melanomas for patients 60 years or younger, also in a very good journal, Journal of Clinical Oncology. And here is what they found. Is there a survival benefit if you perform elective lymph node dissection? No. The patient have the same fate whether you perform it or not. So it was more or less abandoned. You can see the survival curves here for regional node dissection versus observation. So we can conclude, there are more studies, but we can conclude that elective lymph node dissection from a therapeutic point of view does not work. Yeah? But even the proponents of elective lymph node dissection have to admit that even if it would work, yeah, theoretically, only those patients would benefit who have micrometastasis, because those who have not micrometastasis would not benefit from the procedure. So what did they invent? They invented, of course, selective lymph node dissection. This is what we have now, sentinel node biopsy, and if the sentinel node is positive, then you do a selective lymph node dissection only in those patients that have a positive node, and you do not surgery on those who have a negative node. So here's the principle. You all know that. The primary tumor, around the primary tumor, you inject some dye or radioactive substance, and then you detect the sentinel node during surgery. You remove it, and then you microdissect it, and here is the sentinel node as viewed during surgery, and then you microdissect it, and when you're lucky, or when the patient is unlucky, you will find micrometastases that are clinically not detectable in the lymph node, and this patient now has stage 3 and not stage 2. And then you, when the sentinel node is positive, you perform a selective lymph node dissection of the rest of the lymph node basin. That's what we do now, currently. Now the question is, from the beginning, the rationale behind the concept of selective lymph node dissection was not prognostic, it was therapeutic. It was to improve elective lymph node dissection by doing surgery only on those who have a positive node. So from the beginning, there was a therapeutic option. The idea was therapeutic, that we could save the patients when we do surgery on the lymph nodes if they're positive. Now, the concept behind that idea is that melanoma progresses in a stepwise fashion. First you have the primary tumor, then you have the primary tumor enlarges, then you have the first metastasis only in the sentinel node, and then you have afterwards metastasis in the other lymph nodes, and then it spreads to the inner organs. This is the concept of the sentinel node biopsy, and if you stop it here, if you do surgery here, then the patient should be saved, or it should be beneficial to the patient. This is the concept. But this concept, if this concept is true, then the lymph node is a trap. The melanoma cells are captured there and don't come out and don't go anywhere else. And this is very questionable if this is really the case. Is this true? Now, you all know this study. There has been much controversy about this study, but this should have been the ultimate proof that sentinel node dissection is beneficial to the patients. And this guy, you know, is Mr. Morton. He was the first author of this study published in the New England Journal of Medicine, and he's not only a surgeon, he also invented the procedure of sentinel node biopsy. So that's his baby. It's always problematic if you invent a strategy and then make a study about the strategy. But he did that, and this study was a very large study, and it involved hundreds of patients, and there were 2 arms. Wide excision only plus observation, and if there is nodal recurrence later, identified by clinical examination or by palpation or by sonography, you have a complete lymph node dissection, a therapeutic lymph node dissection. The other arm, wide excision and lymphatic mapping and sentinel node biopsy. If the sentinel node is positive, you have complete lymph node dissection. If the sentinel node is negative, you have observation. So if the sentinel lymph node biopsy is of benefit to the patients, this arm should have a better prognosis than this arm. And here are the results. These are the results for therapeutic benefit, and here are the results for prognostic information. Here you see survival curves, and you see this is disease-free survival. We are not so interested in that. We look at this chart here, melanoma.